I'm Elizabeth Stone. I'm a pediatric emergency nurse from Raleigh, North Carolina. I have been I've been involved in clinical research and innovation for about the past 12 years. And my involvements have varied from being co-chair of our first nursing research and innovation council at our hospital, to collaborating with other disciplines to do clinical research and QI, to mentoring emergency nurses and also nursing students in their own projects. I'm thrilled to bring you a panel of 3 innovators from emergency services around the country today. These are our disclosures. So I have no conflicts of interest. The 3 presenters, the 3 main presenters, do have conflicts of interest related to their companies. The objectives of this presentation are listed here. The goal of this presentation is really to share what inspires people to innovate in healthcare. These presenters will be sharing their stories of inspiration, of how they identified problems and decided that they would work to solve those problems. And also they'll share how nurses were involved in some step of that process of the innovation, or of sharing the innovation and helping adopt the innovations into practice. So first, you might be asking, what role do emergency nurses have in innovating? Well, we're actually in a perfect role to be involved in innovation, as you'll learn as you listen to some of these stories and hear what I have to say at the end. We are ideal. We're the ones that every practice, process, or product that touches patients come through. So we see everything. We have our hands on everything. And we are the ones that often are some of the first people in healthcare to identify the need for change or for a process to be improved. Innovation does not mean it's always an invention, having to invent a product. Nurses are often really great at innovating processes or delivery of processes and in healthcare. We are great at identifying ways to do workarounds. Sometimes maybe we shouldn't do them, but we often we create ways to address problems, to fix inefficiencies, to solve problems. We identify gaps in education, and we identify gaps in patient care. And all of these things are reasons why we're in a perfect position to help innovate ourselves, or to collaborate with others to help innovate. At this point, I'm going to share a short video, because this is a nurse from my hospital who has chosen to be very involved in innovation. He is a former ED nurse, and he's now a critical care nurse. He created a website just so nurses and other clinicians could share innovative processes as well as products on nursehack.com, and it's not for profit. I encourage you to check it out. And he was chosen as a fellow in the Johnson & Johnson the first innovation fellowship. So his name is Eric Anderson, and this is his introduction to why nurses should be involved. It's only a 1-minute video.
Nurse innovation as an untapped frontier is, I think, one of the coolest things moving forward for us. Nurses are everywhere that patients are. But even with as many nurses we have, we don't have that much nursing-led innovation yet. I think the biggest thing about innovation is it's so easy to get caught up in negativity when there's an opportunity to make things better. I wasn't able to find any appropriated resource per se that has, all right, so you're in healthcare and you have an idea. These are the steps you take. These are the people you talk to. These are the decisions that you have to make, or the things you have to think about as to is your idea a good idea? Okay, if it's a good idea, is it feasible? If it's feasible, is it producible? If it's producible, can you get funding? If you get funding, can you get reimbursement? And there's so many things that admittedly I still don't know, and that's one of the things I'm excited about this whole fellowship, is learning more about what I know I don't know, so that I would be more equipped to go after my ideas moving forward, trying to make something that will help hopefully revolutionize medicine. I'm Eric Anderson. I'm an ICU nurse at Wake Med, just outside of Raleigh, North Carolina, and I'm very excited to be a Johnson & Johnson Nurse Innovation Fellow.
Today's panel is a trio of emergency physicians who have all innovated in some way that has affected patient care in the emergency department and in the pre-hospital setting. They're going to all introduce themselves and take about 15 minutes to share what inspired them to innovate, a little bit about the innovation process, and about the roles that nurses played in that process. The first one is Dr. Peter Antevy.
All right, Elizabeth, thank you so much. I'm really happy to be here. Thank you to the ENA. Really happy to be on with some amazing innovators. And I'll take a little short while here to tell you my story. I'm a pediatric emergency medicine physician. Been doing this for over 20 years, hard to believe that. And an EMS medical director, been doing that for about 10 years now. So let me take you through how I got here today. And I will say that none of this would have happened if it wasn't for an emergency nurse who pushed me over the cliff here and made me do this. And so let me start off by saying a few important notes, which is I don't like business. Money is not a driver for me. And I never wanted to start a company. But I've always loved resuscitation. I knew that there was something that wasn't right. And I was very stressed out about it coming to the ED every single day. And then I said I had no choice but to try to fix it. And so you could see here that what Eric Anderson said, sometimes not knowing what's ahead is probably a good thing, because if I knew everything that I know now, I probably wouldn't have started. But it's been an amazing journey nonetheless. So for all of you watching who are working in an ED somewhere, I like to put up this case because this is the kind of thing that caused me so much stress, right? My heart rate would go up just by hearing that I had a kid with SVT. But then I became a medical director in EMS, and I found out that when it was an adult, right? So it was a 52-year-old SVT. Well, it was easy, right? We knew exactly what we were going to do. Adenosine. If we had to cardiovert, we give some fentanyl, give some saline. If you vomited, we give some Zofran. And everyone knew exactly what they were doing. They were so comfortable and so confident. Then when we go back to the 2-year-old, they kind of all go back to a corner again. And so it was that, inconsistency for me that I said, why is it that kids are so different? Why is it that I feel so scared when that kid was coming into my ED? I mean, I trained at 2 of the top 5 children's hospitals in the country. I was supposed to be the smartest guy in the room, and boy, was I not that guy. And I've made some major mistakes, and I'm happy to kind of tell everyone this now. It's kind of therapy for me. I gave a child a 10-fold overdose of Epi 1 to 1000 in 2005. She didn't die, thankfully, but her heart rate was like over 200 for a long time. We had to admit her. I didn't realize I made that mistake. In 2010, I realized my medics were making 3-fold overdoses of fentanyl, 3-fold overdoses of midazolam. We're coming in with children not breathing. And we're making these mistakes, not even realizing what was happening. And so this is something that I knew was happening. And I said, you know what, let's try to fix it. And then came the real aha moment, which was resuscitation in the field. So watch this short video and take a look.
James, where are you?
Hey, good morning.
Good morning.
How you doing?
Good, good.
How's Kenny?
How did you disappear so fast? James?
Oh, kids.
James?
Busy and doing in the
Are you
preschool yet?
up here? James? James? James! James! Oh no! Somebody help! Somebody help me! James! James, honey! James!
What happened?
I don't think he's breathing.
Oh, come on.
Calm. All right, help me get him to the ground. All right, James. Come on, James. Gently, gently. All right, gently. Okay, come on.
Hello? Yes.
All right, watch out.
We had a kid drown in the hot tub.
James, can you hear me?
So the aha moment for me was that the lives are saved for pediatrics in the field if you don't do a good job in EMS prior to arrival to the hospital, then these kids just aren't going to come back to life. And as I became more involved and started to understand the world of EMS, I realized that the data bore this out, right? So you look at this data comes from PALS, and you can see that if you're a child and this goes back to the 1980s, who has an out-of-hospital cardiac arrest, the survival is about 6%, and it hasn't changed in decades. Whereas in the hospital, you can see that those numbers rose very rapidly over the years. And here's again the data. Again, of course, PAL just came out with the new guidelines in 2020, just last week, but the numbers are still really the same. So out of hospital, we're not doing a good job. And the question is, why is that? And so what I recognized over time was that for the adult cardiac arrest or the adult anaphylaxis, we know exactly what to do. If you're an emergency nurse and you take care of adults, this guy is easy. You don't even blink an eye. Your heart rate doesn't even move. But if I gave you this kid, suddenly you go to a whole different direction. And this is where I understood that there was a very big gap in what people were being taught. And that's where I understood I was becoming nervous. And this is where the innovation came from. And, I love this room. I love being in this room. But all of us know that everything is upside down in this room, from what dose, what size chest tube, central line, NG, Foley, norepi drip. And there's been so many times where I've called for something in front of mom and dad, and the nurse would say back to me, well, what dose, doctor? How do you want to mix that? Oh, you know what? We have to call Steve from pharmacy. And you can see the parent's face saying, what? Why don't you, how come you're not doing this right here and now? And so this was kind of the moment where I knew that things had to change. And about 11 years ago now, I sat at the desk at the ER at Joe DiMaggio in Florida. And I said, what if I wrote down some ages and some weights, and I figured out what the volume dose was of the 5 medications that I would need, in a pinch. And this is what I came up with. And I have to tell you that I kept it a secret for 2 years. And that one day where Maricar Cabral, and she's out there, and I text with her every single day still, she said to me, Pete, go teach this. And I was giving a lecture the next week to about 200 people, doctors, paramedics, nurses. And it was the first time in my career where I had a line of 50 people who lined up, and they all wanted this one last slide, which was, hey, how do you dose children without having to use a length-based tape or just a small little trick? Maricar did that for me. And I ended up making this little badge buddy. I started flying around the country. People were asking me for these little badge buddies. We're just giving away thousands of these. And then my innovation continued in my brain. I said, hey, maybe there's something more to this. And, I started to realize when I got into EMS that we were taking care of the adult very differently than we were taking care of the child. So as a medical director in EMS, I said, hey, you know what? I'm going to further my innovation a little bit. And then I happen to, understand that in EMS, if you don't treat that child correctly, we never get to this concept of closure. And in an emergency department, if you're a nurse or a physician, if you don't feel like you got the medication in correctly or quickly enough, or you didn't intubate that child fast enough, you'll never get to this concept of closure. And it turns out that the concept of closure comes from what you did before that child died. And so this concept of resuscitations that never end, I was going home losing sleep. I was crying several nights when I figured I could have done better for that child. And I knew that I had to do something more. And so in 2010, Julie Downey, who's now the current fire chief where I work in Davie Fire Rescue, she encouraged me. I went from a badge buddy to a little book that had every single age in it. Honest to God, I did it on my computer. I went to Kinko's and I printed my first book. And then years later, now I'm really fast forwarding, we now have an application that integrates with a lot of the EMS EHRs. We now integrate with Cerner and Epic with our Handtevy hospital program. So again, this is now years in the making. And I'm happy to say that that innovation, that small little day where Maricar pushed me off the ledge, we're now kind of in a different place altogether with integrations with Epic and Cerner. And really it's about no more math. It's about giving better care real-time documentation and improving outcomes is really the mission that we have. And so, and now here we are almost 10 years later. Piehl County Fire Rescue has been using us, and here's the data that they just published. In 2014, we helped them do 3 important things: pre-arrival plan, start CPR immediately and on scene, and give early epinephrine. And you can see here that after Handtevy was implemented at their system, they went from 0 survivors at a 38 arrest to 13, and the average time to epi went from 16.5 to 7.3. And these are neuro-intact survivors. And then it went to 17, and the epi time came down to 5.4. So you could see that they were feeling more comfortable, knowing the dose before they got there, treating the child on scene, and the survival went up. And so for every child that lives, for every family that doesn't get divorced, this is the reason that I wake up every single day to do this. And so it's really been a privilege. And you could see here in green, this is a neuro-intact survival at this county, which has no pediatricians at the EMS system. You could see how many lives they're saving every single year. And this is the study that they published in Resuscitation in February 2019. And then, so lastly, I want to show you a video of a little child named Alejandro, who they actually put this on the news after a save of the same type of drowning that I showed you here just a few minutes ago in the original video.
In Alejandro's case, he had been underwater for 7 minutes, but the crew was prepared.
They got his pulse back within a few minutes, and those few minutes are critical, obviously.
Alejandro was rushed to Jackson's Trauma Center, where he was on a ventilator for 9 days. He suffered brain damage and had to relearn how to walk and talk.
Something as simple as saying, "Mommy," he had to learn how to do all over again.
But Alejandro is making a lot of progress. Both he and his mom are grateful for the paramedics who saved his life.
For going beyond the call of duty and excelling in service that saved my son's life.
A special plaque presented to the paramedics from Station 38, who are clearly moved by Alejandro's miraculous recovery.
It's an amazing feeling. This is why most of us signed on for this job.
It's the same thing in the emergency department, where we're having very similar successes. And so the last thing I want to say is the following, that there's many of you out there who have a vision, who want to do something, just like Eric said at the beginning, that Elizabeth showed you his video, which was amazing. I will say that if you have the vision, you also have to have a little bit of help. So I've been very lucky in my life, so that, you know, I'm just a vision guy, but I married up, and my better half, my wife, Allison, really put everything into place. So make sure that you have a team that can take your vision and move it into the next level. So thank you very much. And I'll pass it on to my, to Mark, who's coming up after me. This is my email, and that's my Twitter handle. So thank you all very much.
All right, Peter, thank you. That was awesome. I had to wipe away a few tears after that first video. So I think I'm back. I got my composure back. So I'm Mark Piehl. I'm a pediatric intensivist. And Peter, I've been practicing a little longer than you, about 25 years. So I got you beat by a few. And I'm also an EMS medical director / medical advisor for our mobile critical care team at my hospital. And I've been in hospital administration for a good number of years, leading a children's hospital, until I started the company that I'll talk about in a minute, 410 Medical, in 2013. So we'll get into how we got there through a patient story as well. I'd like to, Peter, borrow that slide from you, that disclaimer slide, that I also don't like business. Money was not the motivator for me starting a company, and I never dreamed of doing it, nor did I want to, but encountered some problems in my practice and in our efforts at resuscitating children that led me to, with the help of many nurses and with the prompting of many nurses, get into this business that I'll tell you about. So let me start with a story. This child, it's occurred about 15 years ago, was flown to me as a trauma patient. And as most of you are aware, we usually take trauma patients to the trauma bay, but we had multiple traumas at once. And so had to bring some straight to the ICU, and this child was one of them. And she was in hemorrhagic shock, meaning she was bleeding from multiple places: scalp, a skull fracture, chest and abdomen, and probably some long bone fractures. And I remember vividly trying to figure out a way to get blood products into her. She was in shock. She needed volume replacement, and we didn't have a way to do it. This was actually, if any one of you can believe it, pre-IO. This was before we had the easy IO that we could quickly get in intraosseous access. And she was about 10. This is not the actual child pictured here. It was a very similar situation. And I remember calling down to the ED to say, hey, we need a level 1 infuser, which we got up there thinking that would solve our problem. And then no one knew how to use it in the ICU. And we didn't have the right access. And this child sadly ultimately bled to death in our hands. And so really from that day on, I was thinking, there's got to be a better way that I and a team of nurses can resuscitate a patient who is in shock. So let me talk about the problem that we're trying to solve and that prompted me to move into entrepreneurship, and that's shock. It's the ultimate final common pathway of death in most children. And for septic shock and hemorrhagic shock, mortality is high, yet it's a reversible cause of death and something we can anticipate and treat if we get to it in time. And we know that early resuscitation improves outcomes. And one pearl for everyone just to remember is that hypotension in a child means impending cardiac arrest. So in adults, we can tolerate a little bit of hypotension for a little bit of time, but a child most likely will not. And so hypotension is the end of the line of shock at which we need to act immediately. So what is shock? It's basically just not getting enough oxygen carrying blood cells out to the tissues. And tons of things cause it: sepsis, severe dehydration, trauma, anaphylaxis, like Peter mentioned before, SVT. A lot of things can do this. And our goals in treating shock are, first, if there's hypotension, fixing it immediately, usually with volume replacement. And even when there's not hypotension, improving the child's perfusion, the tachycardia, the poor cap refill, the altered mental status, the poor urine output need to be addressed. They're markers of end organ perfusion that we need to fix with volume resuscitation. But it's hard to do. It's hard to get fluids, blood, plasma into a child, or an adult for that matter, quickly enough in certain circumstances, because the tools we use to do it, the access that we have available are not often, and the hands we have are not often sufficient. You probably all are aware of something called the RORY STAUNTON Foundation. RORY STAUNTON was a boy who died of septic shock, under-recognized, under-treated at several hospitals, and his parents ultimately founded this organization dedicated to helping clinicians and the lay public better understand sepsis and recognize and treat septic shock. And so their work and the work of many other organizations like the Sepsis Alliance have helped prompt us all to try to improve the way we treat shock in children in hospitals. But as important as sepsis is trauma and traumatic injury is even more important. So trauma is now the leading cause of death in children in the US. And note, on this top 10 cause of death in children in the US, sepsis does not even appear on the list. It's not there. It's important, but it's a small cause compared to MVCs, firearms, drowning, suffocations, fire, burns, and all these things can lead to shock, and we need to know how to treat it. So how do PALS, American College of Critical Care Medicine, Surviving Sepsis, teach us to treat shock initially? After we've recognized that there's ultraperfusion, there's tachycardia, there's poor perfusion, what do we do? Well, I could lecture on this for a couple of hours, but it has to be distilled into a couple of minutes. And so our first intervention in most cases is to give a fluid bolus. And that's usually in volumes of 20 per kilo, maybe 10 per kilo for neonates, or if we're worried about heart failure, but 20 per kilo to reverse shock and then reassess. This is the American College of Critical Care Medicine guidelines, which also states that we should provide 20 ml per kilo boluses by a rapid infusion device by which they mean a pressure bag or a syringe push, trying to achieve normal perfusion and blood pressure, and watching always carefully for signs of fluid overload. And children may need 40, 60, or even more per kilo in the initial stage of resuscitation. The brand new 2020 Surviving Sepsis Campaign guidelines, I'd like to point out, adopt a more hesitant approach to fluid resuscitation. And if you notice at the bottom, fluids are not number 1, they're number 5 on the list. This hesitation comes from the results of a trial in Africa where children largely with dengue and malaria in sub-Saharan Africa were given fluid boluses and had slightly increased mortality when they got fluids. And so folks have thought, wait, are we doing the right thing by treating kids in shock with fluids? And I would submit that that FEAST trial is not applicable to most of the children we encounter in the developed world. And so I'm not 100% in agreement with the line that this surviving sepsis guideline takes on fluids. We need to recognize shock and treat it immediately, and that often involves a measured fluid bolus. Quickly to trauma, what does ATLS teach us? They also recommend initially 20 per kilo boluses of fluid, though that is becoming controversial. Ideally, we'd give blood first, but in reality, most of us have access to fluids and we'll give that in 20 per kilo doses. If the patient's still in shock, then move to 10 to 20 per kilo doses of packed cells or ideally fresh whole blood. We know that the evidence shows us that reversing shock early improves outcomes. And in most of the studies that you can find out there, this is all done with early fluid resuscitation tailored to reversal of shock and while watching for any signs of fluid overload. And we know that in all the QI studies and prospective studies that have been done on this in septic shock in children in the US, we see that earlier fluid resuscitation reduces mortality, organ dysfunction, things like renal failure, and hospital length of stay, and ultimately cost. So how do we do it? How do we then actually get a dose of fluid into a child? How was I to give blood to the child that was dying of hemorrhagic shock in my ICU? Well, there's lots of stuff out there we could use. There's a pressure bag, something PALS recommends. There's a syringe and a stopcock. You could just squeeze the bag like a tube of toothpaste, which is often done, super inefficient. Or better yet, let's put it on a pump and push 999. That's really fast, right? Well, in reality, we know it's not. That's 1 liter per hour and is sufficient to get 60 per kilo of fluid in a child only under 4 kilos in an hour. What does PALS teach us? Basically take a 3-way stopcock, deliver fluids with a 30 or 60 ml syringe, and then withdraw from the bag again and deliver the next dose. They also discuss the use of a pressure bag, but warn, rightly, that you can give an air embolism if you have not de-aired that bag of saline or LR first. So be super cautious with that if this is your preferred method of giving fluids. There's actually little agreement on the best way to do the syringe method, but many studies have shown that 10 and 20 ml syringes actually work the fastest and create the least work. A pressure bag has to be continually reinflated and carries the risks I mentioned, and that we often don't meet PALS guidelines in any situation with any of these methods. So what I'm about to show you is a video of one of nurses in our emergency department trying to administer fluid to a child in septic shock. And you can see she's taking out a 60 ml syringe and she's pushing fluid through that tibial IO. This child needs about 1 liter rapidly. She's hypotensive modeled, and it's really hard to do that. So she switches over to a 10 ml syringe, and then note how quickly and easily she's able to do it. The problem is she needs to do that 100 times to get the liter in. And every time that plunger is withdrawn, bacterial contamination can enter the syringe. So it's what we do, but it's not necessarily optimal. And this is an image of a trauma patient of mine where we were doing the same exact technique with packed red blood cells in a child in hemorrhagic shock. So all of these experiences, working with my nurses, struggling together to resuscitate kids effectively, watching people struggle with the syringe and stopcock technique, led us in our simulation center, really with a ton of nurse partnership, to develop a device that essentially made this process easier and allowed us to more quickly administer a reasonable fluid bolus to a child in shock. And I'll show you an image of that, video of that here. So this is Sarah in our sim center. Who's going to quickly take out the device, which is called LifeFlow, spike a bag of whatever we're giving, LR, saline, plasma light, prime it, and then attach to the child's IV or IO access. And then she can quickly deliver those 10 ml boluses and can get 1 liter in, if necessary, in under 4 minutes, even through a 22 gauge. Not that every child needs 1 liter, but you can do it quickly with one hand and then quickly reassess that patient and decide that worked, or I need to give a bit more. So it overcomes the inefficiencies and some of the safety problems that we've had with other infusion techniques. So let me run through a quick case where we used a LifeFlow and resuscitated quickly and show you the outcome here. So this is a 6-month-old baby. Mom found unresponsive and gray in the crib. The heart rate was 245 in the field. The paramedics thought this must be SVT, gave appropriate doses of adenosine, which didn't work. In the ER, we gave more adenosine, that didn't work. Cap refill was long. A quick blood gas showed this child was in trouble. Low pH, lactated 9. We popped an ultrasound probe on and found this kid was severely dehydrated. This might be septic shock or severe dehydration from diarrhea. Through a small IV, pushed 40 per kilo quickly. And you can note there on the EPIC vital sheet, the heart rate immediately responds. The best measure of perfusion improvement in a child is the heart rate coming down, 50 points in 3 minutes. We knew we were doing the right thing. This child ultimately got 200 mils per kilo of fluid, never went on pressors, lactate resolved. We did intubate him, and he left the hospital in a couple of days. So rapid resuscitation, rapid reversal of shock makes a big difference. So this has led me to this concept of improving the slope of resuscitation, which is our typical pathway is the slow upslope line where we take time and struggle to get volume into the child, whether that's blood, plasma, or fluid. And then over time, it forces us to give more and more and more, and we ultimately over-resuscitate. Whereas if we could reverse shock earlier with the right amount of blood or fluid given quickly, get the child to the ICU quickly, we can de-resuscitate quickly and actually result in fewer interventions and fewer complications. Let's stop there. We can maybe Elizabeth can ask us some specific questions later, but I'll pass it on now to Teresa.
So thank you, Peter and Mark, for those amazing stories, and it's just a pleasure to be here speaking for innovation and the value of innovation in healthcare. And I want to share a little bit about my story. So I'm Teresa Riech. I'm a pediatric emergency physician and the medical director of the Pediatric Emergency Department at OSF St. Francis in Peoria, Illinois. And I'm a former military, both medic and physician. I'm retired now. And I've been in healthcare for about 20 years, but only as a physician in this role for about 10. So I've had the pleasure to work with teams in all types of settings, pre-hospital and in the hospital and the emergency department more specifically. And I want to speak a little bit about training today because all the things that we have at our disposal in the year 2020 to resuscitate patients and to take care of patients, really the Achilles heel sometimes is the training of our staff and how to deploy and to use the tools that we have at our disposal to the best of our ability to resuscitate patients. So I've witnessed, I think both of you, Mark and Peter, I think you both discussed some angst that you've had personally related to patient resuscitations that maybe didn't go quite as planned or quite as ideally as you would like them to. And I think we all struggle with that. I've watched particularly our newer staff members. So I've seen nurses and residents that are early in their training or early in their careers involved in a case that had a bad outcome, or there was just something that didn't work quite right. And I just see how they struggle with that. And even with doing a debrief after a case like that, it really takes a toll on us as humans and as healthcare providers. And, I've seen staff who just sort of can't get past that, kind of blaming themselves for what things might have been done better. And I think really the way we mitigate that for our nursing staff and for our physicians in training and our respiratory therapists and radiology techs and all members of the care team is to give them the best training that we possibly can going into those cases and to really provide them those skills to fall back on so that they feel confident in moving forward. And I think it's a tragedy to see a young career, someone who's really gung-ho about taking care of patients to maybe move on to something different, to go into a different care setting because they have a case or a couple cases that are really tough, and they just feel like I'm not cut out for this. And I think we can sometimes stop that from happening by preparing them really well in advance. So that's what I'm going to talk a little bit about today. Our medical residents, I think, are struggling, sometimes with this, and I know our nursing staff work very closely with our nursing educators, and we try to identify the highest risk type of resuscitations and conditions, and we really try to focus on those in our training. So in 2018, this was a survey that was done of medical residents, over 1,900 residents across 29 specialties all over the United States. And they identified their top 6 challenges in training, including work-life balance. A third of them identified this as an issue, dealing with time pressure. So trying to get training in the middle of living life and all the other things that happen around us. Their fear of failure or making a serious mistake, whether that's real or perceived. Developing clinical skills required for their specialty. And this, I think, is even more of a challenge today than it was when this survey was taken. Debt and the pressures to pay off your debt while you're also trying to establish yourself as a specialist, and dealing with the stress. So we work in really high stress environments. Even those of us that aren't in the emergency department in the ICU, we really have high stress environments in healthcare these days. And if you add to those some unique stresses and strains in the training pathway of nurses, I think it's even more. Difficult. And some of those are nursing shortages, differing requirements state to state. It just really creates a challenge. And I think what we saw both with Peter and Mark, adversity sparks innovation, and that's really what happened at our institution. And I think we really opened a door to some amazing training tools that really started because we saw that there were some problems. There were some chinks in the armor in terms of our ability to train our staff. So this is a picture of Dr. Matt Bramlett. He's a good friend and colleague of mine. He's a pediatric cardiologist, and he does a lot of work in innovation. So I'm fortunate enough to work in a place, OSL Healthcare, where we have a state-of-the-art innovation and simulation center. So we do lots of innovative work there, both simulation, but also work with engineering to create solutions to problems that we identify. And so Dr. Bramlett started doing 3D printing of congenital heart defects. So as you know, there are sort of the textbook presentations of various congenital heart defects, but every baby that's born with a congenital heart defect, their heart is different. So there are subtle differences. And traditionally, the way these would be repaired, they would have 2D imaging, so MRIs and echoes, but the surgeon never really saw the heart to be repaired until the chest was open. They really saw it in, sort of to inspect it until the baby was on the operating table. And so back in 2016, they started doing segmentation from imaging, and they would create these hearts and print them in 3D. So they actually get what you see here, a 3D plastic heart. And segmented here, you can see it can be taken apart, sort of like a little puzzle. And the surgeons were able to actually do some preoperative planning on this. Well, there are some limitations to this. This was an amazing step forward in terms of surgical planning, but there were some issues. So Dr. Bramlett got a grant and started doing segmentation of hearts, and started an NIH print exchange where actually they would upload these different images, and they would create these 3D digital files, and then people could print them wherever the child was, and or they would actually send the imaging to our institution, and we would print the heart, a physical heart that you see here, and then it would be shipped to the institution where the child was being cared for. So that was a step in the right direction, but obviously there are still some limitations. And one of those is that it can't be resized. So it looks just the way, it's just a tiny heart, just the way it will look in the child. So it's very difficult to kind of zoom in and get a little closer inspection. And this is a very expensive process. And so from that came the idea that we could recreate those digital images and put them into virtual reality. And then we could actually play around with them and resize them and sort of cut. You see here, this is one of our cardiothoracic surgeons, and he's actually using a cut plane to sort of pan through this heart in 3D. And the idea was to do surgical planning for this. And this digital file was instantly transferable to a treating facility. And the surgeons found that about 80% of the time, they would actually change their surgical approach based on seeing that anatomy in real time. But what we noticed was that when the surgeon would put on the headset and would start examining the heart, he or she would actually start to talk about it. So there's like this sort of teaching, and you'd hear them saying things like, well, here's the outflow tract, and you can see that the defect is right by the AV node. And then it just was an aha moment that this would make an amazing training tool. If we just record this conversation that the surgeon was having, and that's exactly what happened. And so Enduvo was born. This is a 3D virtual reality immersive training platform that you can create this file, save it, and then someone else can open up that file, and it's as if they are right there with the person doing the recording. So I'm going to step back for just a second. So that's the tool that was created, and actually that became a startup company that sort of branched off from the Innovation Center and became a startup, and Enduvo is now about 2-3 years old and has grown, and many improvements in the software since what you saw there. And then today we fast forward to the days of COVID, and you know, I talked about all those training barriers that we have at baseline, and now we have compounded that tremendously. And these are just some of the additional challenges that we have in the era of COVID. So things like social distancing, so we can't have classrooms, lecture halls, group meetings the way we typically do. How do we teach procedural skills? That's become more challenging. That preclinical curriculum for nurses and physicians, online formats for things like basic sciences and group virtual team settings, which sometimes take away part of the experience of learning in a team setting at the bedside. Trying to take exams that normally would be paper, pencil, or direct observation, trying to adapt that to an online setting. Some of the effects of isolation on students, so you don't get that real-time feedback. If you're doing a computer-based training module, for example, you're not actually hearing from the expert right there. Corrections of behaviors or feedback, that type of thing is sort of hard to recreate in a two-dimensional setting. I think boundaries on our personal time, so it's a little harder for us to sometimes draw the line and say, no, I'm post-call, but that's when the meeting is scheduled that I need to be learning. So some of those issues, I think, have been a struggle. And students are, you know, they're an important part of the team. So their inquisitiveness right there in the moment when you're doing a resuscitation or you're taking care of patients at the bedside, if students aren't in the room, then sometimes, you know, we don't push ourselves as experienced physicians and nurses to sort of question, why do we do things the way we do? So students are an important part of that team, you know, just in terms of keeping our eyes young in our experience with patient care. And then a lot of that student professional identity relies on teaching and role modeling and all those things. And that's all become much more difficult. And then there's this risk mitigation. So what about our learners that maybe have healthcare problems, underlying risk factors for COVID? And so they have to be maybe removed from the care setting where there may be risk for infectious, being with infectious patients and that type of thing. Or PPE. So if we have issues with PPE shortages, which we know has been an issue, we have to sort of trim down our care team, and that often takes our students away from the bedside. And then there's geographic differences in the training pathway. So I just pulled these are just a few examples. There were actually there were different guidance in almost every state and municipality in terms of the nursing curricular and board requirements. So in 2020, I think a lot of the governing bodies that help to do accreditation, they all had to struggle to come up with how do we get these nurses and physicians out into the workforce safely and competently. And in order to do that, there had to be some accommodations made, and that looked different everywhere. So every one of these governing bodies had to come up with their own set of guidelines. And as you can see here, they're very different depending on the geography. And so that's just yet another struggle. So, you know, locally, we've talked about how do we create clinical encounters? So how do we, if we can't have students at the bedside, if we can't be teaching them in real time, how do we recreate those encounters so it's as if they have had at least some exposure to any particular clinical condition? That experiential learning is really important to solidifying taking a clinical condition and from the textbook to real life. It's really important that you actually see those patients with whatever X, Y, and Z clinical problem. And how do we reach entrustability? So how do I know that my students or our nurses in orientation, how do we know that they are ready to take care of those sick patients if we don't get to observe them taking care of those patients, or if we don't know if they ever have actually seen a child with severe asthma or anaphylaxis or a drowning patient? And then how do we develop those critical thinking skills if we don't have the luxury of walking through a clinical case, doing a debrief and witnessing it in real time. You know, the old adage in medical training is see one, do one, teach one. But what we're really struggling with is our learners are sometimes not being able to do step one. They can't even see the one case. So we have to find ways to get around that. And that experiential learning happens by, as you see here in this circle, observing the experience, then reviewing it, doing a debrief, analyzing, going back and reading about that condition, applying the lessons that were learned, getting feedback, asking questions, that sort of thing. And then the next time around, when that condition is presented, then being able to reapply what you learned the first time around. And the benefits of that are deeper insight, longer lasting learning. I think we all probably have a case, you know, in our head, you know, my first GI bleed patient, and you know, I'll never forget what Betty looked like when she came in and how we intervened. And it just sort of solidifies all those things you've read when you see it in person. And that's really what we want to recreate. So we had this proof of concept in teaching our students the recognition of critically ill, decompensating patient. It's a challenge, and we don't have all the opportunities we want to assess the critically ill patient, to recognize life threats, communicate the patient status, and initiate life-saving interventions. So we created some clinical cases, and so we wanted to sort of artificially create the conditions around taking care of these patients. So our methods were standardized patients that we moulaged and we recorded in these little Cineloop videos, kind of like a GIF. And we created 2 cases. So this is one of the cases. This is a child with asthma. And this is actually my son. He does not have asthma, although he's a little bit of a hypochondriac. So now he thinks he has asthma. But he was really good at pretending he had asthma. And so we sort of walked him through and coached him through what it looks like as a child kind of progresses through the stages of worsening asthma and worsening asthma exacerbation. And then we created a very similar case with an adult with unstable SVT. And so we recorded these video loops, and then we put them into this virtual space, and we worked in the pathophysiology of both of these conditions. And I'm going to show you what that looks like here in a second. But it allows the learner to go in, and we have loops of vital signs corresponding with every stage, mild, moderate, and severe of asthma, SVT. And then you actually have sort of the video of the patient there in front of you and seeing in real time what that looks like. So I'm going to try to show you. Maybe.
Once we started some oxygen therapy, I'll show you.
So as you can see here, so you see in the background, there's a 3D model, and the purpose of the model is actually to demonstrate the levels of the respiratory tree and kind of where obstruction happens in asthma. And then we have some clinical pathways and some, you know, you see some prompts there on the left where we actually show where intercostal retractions are, for example. And then we're able to pull in images of various oxygen delivery devices and how do we give nebs. And we walk through each stage of therapy at every level of severity. And so we put 20 learners. So we started with medical students, and then later we've moved on to pre-hospital and nursing personnel. But our initial trial was with medical students. And we put them through these modules, both cases, and then we asked them their confidence. So how confident were they? These were third-year medical students, by the way. How confident were they in managing these 2 clinical conditions before and after going through the training modules? As you can see here on the left, ahead of time, there were 25% of the learners had no confidence in managing those conditions. And then there was a very small proportion, so about 5% of them felt completely confident. So those are the learners that already thought they had this in the bag. And then you can see the shift to the right after doing the modules, the shift in confidence level with managing these conditions. And this is without actually seeing a real life person with asthma or unstable SVT. And then we asked them to compare this VR training experience with traditional classrooms, so like lecture-based training experiences. We know that it's not exactly the same as a live patient experience, but this comparison with lecture. And none of the students in the pilot felt that this was inferior. In fact, 45% felt it was equal, and then 55% actually felt that this was a superior experience, in part because they kind of had control of the timing. So they could go back and re-listen to things and play them again or mess around with the model and kind of really get a sense of where the bronchioles are and the alveoli and et cetera. And they actually could kind of do the lesson at their own pace. So some of the advantages that we're finding with this type of model are the ability to scale it across geography. So I can record a lesson here and I can send it to anyone, anywhere in the country for viewing. It's very adaptable. So in the beginning, we started doing back in March, when we just started learning about COVID-19, we recorded a series of lessons on SARS-CoV-2. And that information in terms of therapeutics in particular was changing daily almost. It seemed like we could give steroids and we couldn't, anti-inflammatories were okay, hydroxychloroquine was okay, then none of that was. And so all of those things changed. So we could go in and just tweak the lessons as the recommendations were evolving. Safety in terms of not having to actually be in proximity to a patient. And the immersiveness is really interesting because, you know, when we put our students into the headset, they often spend much more time than the actual recorded time playing around and learning kind of at their own pace, which is, I think, really remarkable in terms of the attention span of our learners today. Also, as we've observed our learners in the headset, we've not had any students who stop and check their phone. So you'll see, as you're watching them in the lesson, you'll see their Apple Watch will go off, their phone, you'll see buzzing, you know, light up, and not one of them ever takes off the headset to look at it. So they really have this immersive, concentrated period of training. There are always some disadvantages. Obviously, it's not an actual patient, so there isn't sort of that muscle memory of touching the chest and feeling, you know, a bruit, for example. Those things we can't replicate. And it doesn't also take into account the breadth of the patient presentation. So we can make the textbook cases, we can allude to some of the differences that you might see, for example, age-related differences or those types of things, but it's really hard to kind of show the very nuanced presentations of various clinical entities. But it does get us closer, I think, than textbook or PowerPoint or those type of thing, of course. So some of our current projects and future directions, we created our institution. We had a 30-hour EKG lesson, EKG course, really intensive course for our ICU nurses. And we were able to recreate that into Enduvo and into the virtual space. And now it's about 4 hours of recorded time. And it can be self-directed learning. So we don't have to schedule it on your Saturday off. You can listen to it or play it in sort of chunks of time as your schedule allows. We're working on creating a library of clinical encounters for nursing, medical students, and residents. There's some resuscitation pre-hospital modules. This is an example here of a module that we made for the military on needle decompression. And you can see we can actually show them exactly where to put the needle to decompress the chest, and the learner can actually do that in the virtual space, which is pretty remarkable. And then this is the COVID-19 lessons that I mentioned to you. I won't pull it up here, but you can actually go to YouTube and just type in Enduvo COVID-19, and you can see the series of lessons. These were created by one of our medical students who did multiple lessons on therapeutics, evaluation, and even a lesson for kids about hand washing and how to put on a mask and those kinds of things. All that's open source, so you're welcome to go and check it out at your leisure. So I'll give it back to Elizabeth just to talk, but I just want to say again, you know, every member of our care team is important, and the more time we're able to invest in the training of those team members, the better outcomes for our patients. And I think at the end of the day, that's really the most important piece.
All right, thank you to our three panelists. We're gonna wrap this up. I'm gonna ask each one a question or two, and then I'll wrap it up with a couple of closing suggestions for nurses who are interested in becoming involved in innovation. First, I'm gonna start with a question or two for Mark Piehl. Mark, I know that there's a lot of overlap between the technologies that have been discussed today. I was wondering if you could give us an example of how they might all be used or they might all work together in some way.
Sure. In fact, we have had an example of that in the last few days in our own hospital system, where a child not known to be allergic to cashews ate a cashew and developed anaphylactic shock at home, and the paramedics in our county pulled up the epinephrine quickly using the Handtevy system. So they've implemented that, and it enabled them to get to the scene knowing the age of the patient, prepare ahead of time, and be ready to go with the right dose. Not a 10-fold overdose, not struggling on the scene to figure out how much to give, but the right dose. And that child then ended up in our ER in shock. So after 3 doses of epi-IM, still was hypotensive. And remember, I said hypotension is a situation that's dangerous in a child. They're about to fall off the hemodynamic cliff. And so our nurses were able to get out of LifeFlow and give that child 40 per kilo in a couple minutes and effectively restore their perfusion. Then he needed an epinephrine infusion. Well, how do you calculate that? You need a reference. You need a way to remember, okay, this is how I quickly make up an epi drip, or use a push dose pressor. Again, the Handtevy app allows you to do that, or some tool that's ready on your phone or on your workstation to teach you exactly how you're going to mix up that fairly confusing drug. Epinephrine I find to be one of the hardest drugs to dose. And all of that we have simmed before in our simulation center with paramedics, with nurses, with docs. Now, not necessarily that very scenario, but the muscle memory, as Teresa mentioned, comes from, and the mental memory, knowing what to do next, comes from simulation. And I'm really excited about this VR platform because it's harder and harder to get people live into the sim center and sim every possible basic scenario you might need. And so being able to do that with these standardized scenarios virtually is a really exciting opportunity. So yeah, it's come together. They're synergistic, and they all help us take better care of sick kids.
Great, thank you. And I'll stay on you for one more question. I know because we work at the same hospital that a little bit about the challenges of the FDA process, and that's a big deal. Could you speak a little bit to that, kind of what the FDA process is like?
Yeah, and I don't think either Peter or Teresa's technologies require an FDA approval, whereas a therapeutic or something that you're using to treat a patient or administer a medication like fluid would. And that's been a long, hard, going from a great idea to an actual product in nurses' hands is a long, expensive, difficult road. So I guess I would be answering one of those barriers to innovation. It seems like an overwhelming process, and it is. But it was actually, again, to tie all of these together, it was actually a group of nurses willing to help us in our simulation center that allowed us to go through the motions to do the testing necessary to get the FDA approval. So it was actually kind of a fun process, and we learned and redesigned in that process as we put folks through simulated shock scenarios and said, how does this work? How does this device work? What are the potential pitfalls here? How do we improve upon them? So it's been a long road. We've been through 2 FDA processes, one to give fluids, and now we just got approval for giving blood products. So treating that original child I told you about with who died 15 years ago actually is now possible. So now that we've gotten through that long FDA process to give blood products with our device, and that is approved. But it's not easy, and it's a big, as Eric mentioned initially, it's a big perceived barrier. The hurdles are huge, and you need partners. And both Peter and Teresa have shown how partnerships with lots of folks are able to carry you down the road where you don't have the expertise on something like FDA, which I didn't.
Wow, thank you. All right, Peter, could you speak a little bit about some of the barriers you've encountered to innovation and to introducing innovative products?
Sure. Do you have about 4 hours? Well, okay. And all kidding aside, and first of all, Mark has a lot of black and blue on him. He's had a lot more barriers because of the FDA, but thanks to him, many more children are alive today. So I really look up to someone like Mark. For me, I think that the barriers, there's 2 big ones for me. Number one is yourself, right? There were nights I was waking up in the middle of the night and my wife was like, what's going on? And I said, I have to do something. And I finally just, I'm just going to do it, right? But then probably the harder one after you say, I'm going to do something, is all the people around us, our colleagues. And so I would advise people to read a book called 0 to 1, which is a book by Piehl. And a 0 to 1 idea is an idea that when you talk to most people, 100 people, 95 of them will think it's the dumbest idea. They've never heard of it. You're crazy, Pete, for doing that. That's when you know you have a winner. Then, right. But that's when you have to go and find the early adopters, the Julie Downeys of the world, the Maricar Cabrals, who believe in you and say, hey, you know, it sounds crazy to me, but go do it. Like what Teresa's doing. I mean, look, it starts with something and you cross the threshold and then it turns into something else. And so rule number one, don't listen to all the people who are telling you no, because if the idea was that easy, it would be out there in the world already. So I think those are the two big barriers I would caution people of. And once you're on the road, it gets much better 10 years later.
Thank you for that, Peter. And last but not least, Teresa, I was wondering if you could speak to some facilitators that you encountered or supports that you found along the way to innovation.
Sure. Well, I feel really fortunate that I happen to work in a tertiary care center that has a simulation and innovation center. So I realize that's not everywhere. But I will say that innovation happens everywhere. And often the best ideas come from the humblest of settings, because that's where the adversity, or that's really where the struggles are happening. You don't maybe have every tool right at your fingertips. And, you know, in the military, we had lots of ideas that came out of the field because we really had to be more agile and to sort of come up with workarounds because we had a lot of limitations. And so no matter what your practice setting is or what your location is, there is innovation that is happening. There are great ideas that are happening, and where to seek out how to implement those or to take those forward is becoming, I think, easier and easier. So there are lots of innovation centers that you can go to. There are a lot of grants and funding sources to fund innovation and research and development for those types of things. So you don't have to go it alone. I think seeking out a mentor or research department within your own institution or at the closest innovation center or tertiary care center. You know, our ears are always open for ideas that come from elsewhere, because there are lots of great things that we have not thought of, and yet we have some of the resources to take some of those things forward and actually try them out. So so I think there's lots of avenues. I think I don't think you should feel in this day and age that even if you have a great idea, that it's this daunting, impossible task to take that into the real world. So don't stop.
Thank you. That's great advice. And actually that mirrors some of the things I was going to say. So just some closing advice from me as somebody who's been involved in innovation, not necessarily invention, but in innovation in some way, whether it be process, quality improvement, research, finding gaps in education and working to solve those. There are more and more resources out there, and there's more and more support out there now every year, as Teresa was saying. I'm particularly impressed by the Johnson & Johnson company, and I have no relationship to them, but if you're interested in innovation, I definitely recommend that you check out their website. They have these quick fire challenges that they post. It's a continuous thing. They keep coming up with different types of challenges that are focused on a certain population or problem. And it's basically a call out for applications for suggested solutions. And they're looking for process solution, technical, technology-based solutions, or products. It runs the gamut. And this is a call out to nurses to help them solve problems. They also have a really neat See You Now podcast that features things that nurses are doing around the world as far as in innovation and process improvement. And a lot of it is actually technology related. There's a lot of applications that nurses are developing for their patients, that they have the knowledge to know what their patients need, and they put that into use to really help solve problems and improve outcomes. And there's also a lot of awards. ENA has grants and scholarships that can be used for innovation, for quality improvement and research. ANA is another major organization that has some awards. Hospitals more and more, and just healthcare organizations in general, are really starting to recognize the role that nursing should have at the table when it comes to innovations. And it's important to remember that innovation does not mean invention, and that there's a very broad description of what innovation is, and there's many roles that we can play. And just a couple things I'd like to say, and just to wrap this up. In closing, I found that the nurses and the other healthcare professionals, and just other professionals in general that I've met that have chosen to be involved in innovation and research in quality or process improvement have really been some of the most passionate and engaged people that I know. They're the people that I want to work with, and they're the people that help keep me motivated and wanting to do more for my patients and for others. So I hope that you learned something from this presentation. Feel free to reach out to any of us. I know my emails are on the presentation itself, and you can reach me at either one of those. And I thank you for attending today.